Bismillahirrahmanirrahim. Assalamu alaikum. Welcome to my YouTube channel, Dr. Shabnam Nas. Today I have to deliver the lecture or small session on the new exam format by a CPSP for Fcps 2 clinical, that is extended talks. So बहुत सारी कैंडिडेट्स को काफ़ी सारे इश्यूज थे, काफ़ी सारे प्रॉब्लम्स थे कि ये न्यू मेथड क्या है और कैसे हमें असिस्ट करेंगे और ये एक्सटेंडेड टॉक्स कैसे होगा, कितने टॉक्स स्टेशन होंगे, कितनी इसमें कितना टाइम होगा और क्या क्या टाइप्स होंगे स्टेशन के। तो आज हम ये बात करेंगे इस सेशन में। एक्सटेंडेड टॉक्स, दिस इज द न्यू एग्जाम फॉर्मेट बाय अ CPSP फॉर FCPS 2 clinical, and that is the standard by RCOG and by ACOG. Types of the stations, कौन से मॉड्यूल्स चेक होंगे आपके, कौन से मॉड्यूल्स बोले, चैप्टर्स बोले या सेशन बोले। तो ऑप्शन गायनी is divided into following chapters. See here the teaching in which you teach your junior. CPSP examiners will assist you the method of the teaching, how you teach your juniors. Then the session of the urogynecology, gynae oncology, labor and the delivery, puerperam, antenatal care, maternal medicine, fetal medicine, benign gynae problems, menopause, sexual and reproduction, infertility, core surgical skills, pre and post operative care, obstetrical emergencies, risk management and clinical governance. इन सारे चैप्टर्स में से और इन सारे मॉड्यूल्स में से कोई भी स्टेशंस आ सकता है, वेदर अगर वो टीचिंग में से दे रहे हैं, यूरोगाइनी में से दे रहे हैं, गाइनी ऑन्कोलॉजी में दे रहे हैं, दैट्स डिपेंड अपॉन द CPSP examination department, and that's by examiners. How many number of the stations? Usually 12 to 14 numbers. So 12 भी हो सकते हैं, up to 14 भी हो सकते हैं. So most probably 12 stations. Time for each station is the 12 minutes. 2 minutes outside the cubicle where the task is displayed outside the cubicle. Once the bell is ringing, you have to read the task carefully outside the cubicle and write down in one paper in the bullet form or in capital letters what is the important point which you have to discuss inside the cubicles. So see the task carefully and what they are assessing you that are written in the last of the task, right? Okay, so 2 minutes outside the cubicle. After 2 minutes, the bell is again ringing and you people will enter into the cubicles. Inside the cubicle, there are 1 or 2 examiners for your assessment. They have key, pre-decided key by CPSP examination department related to the task. So they will just assess you, and there is one role player that would be a patient simulated or a junior colleague. So वो या तो patient हो सकता है, patient का role play करेगा, या वो junior colleague का role play करेगा, आप उसको teach करेंगे. So one role player, that would be a doctor or that would be actor. They are trained in their acting, so you don't need you don't have an interaction with a real patient. They are the simulated patients. Specify 1 or 2 examiners on the same stations and the 1 role player. So same task will also displayed inside the cubicle on the table. If in the 2 minutes you haven't finished the task, you will take a permission from your examiner that I haven't finished the task properly, so I want to read it again. So after taking the permission, you have to read it on inside the cubicles. But make sure your 10 minutes are counting once the bell is ringing inside the cubicles. So आपके वो 10 मिनट वाला टाइम काउंट हो रहा है जो आप अंदर आके भी देख रहे हो. So ट्राई यही करें कि आप 2 मिनट में वो टास्क बाहर ही कंप्लीट कर लें. इतनी प्रैक्टिस करें उस टास्क को रीड करने की कि यू हैव टू रीड विद इन 2 मिनट्स एंड अंडरस्टैंड व्हाट दे आर आस्किंग एंड मेक देम इन द बुलेट पॉइंट्स. ये 2 मिनट बहुत ज्यादा है, अगर आप प्रैक्टिस करोगे तो आप 1-1.5 मिनट में ये कर लोगे, राइट? सो दिस इज टोटली द एग्जाम ऑफ द प्रैक्टिस एंड द एग्जाम ऑफ द असेसमेंट ऑफ द सॉफ्ट स्किल्स ऑफ द कैंडिडेट. सो व्हाट टाइप ऑफ स्टेशंस these could be teaching your junior colleague, patient simulated task, structured viva, labor board or a gynae board. So let's see the example of the teaching from a teaching module. So this is the task which is displayed outside the cubicle. You are about to see Saira, who is taking her IMM exam. She wants you to teach her about a ring pessary insertion. You have 10 minutes during which you are expected to conduct a teaching session on pessary insertion. Answer the doctor's concerns. You will be assessed for. Look here. These are the 5 domains you will be assessed for: communication with colleague, communication with the patient, information gathering, patient safety, and applied clinical knowledge. So these 5 domains are assessed by examiner. This is the teaching template. How will you start the teaching? First, you start teaching with introduction. Introduce yourself. Hello, I am the registrar or co-resident, and you are. So ask her name. If she is, so she will tell you that I am Dr. Flan Flan Flan. So break the ice. If newly joined the unit, you say, I heard that you joined us recently. How is it going so far? If a resident who has an exam like in your task, so say that, I understand that you have your exam around the corner. How's your preparation so far? I wish you the best of luck. After that, you have to confirm the aim of meeting. What's your aim of the meeting? I understand you are the one who wanted to know about more the pessary insertion. Is that right? Then ask why they want to know. Can you tell me why you are interested in the pessary insertions? Check what he already knows. Naz, have you ever seen her done this before? To see her previous knowledge before she inserted, she knows it before. So what are you expecting from these sessions? What are your expectations from today's sessions? Set your agenda. Set your agenda means plan of today's meeting. What you are going to do in today's meeting. This is your agenda. So provide teaching plan outline. In the next few minutes, we are going to start, or we will do a discussion on plan, right? So whole teaching plan. Provide opportunity for the questions and potentially time to practice at the end. At any stage, feel free to ask anything in your mind. You feel free to ask. So at the end, you will give her the plan of the discussion, the plan of the agenda. Usually the drills are assessed in the teaching stations like the vacuum, like the UCG insertion, migraine insertion, manual vacuum aspiration, forceps delivery, or shoulder dystocia, neonatal resuscitation, maternal CPR. These are the drills, the bladder repair, the gut repair, or how to make the multidisciplinary team referral letter, consent for cesarean section or for hysterectomy or for medical termination to your juniors on these stations. These are the which are given in stations. Basic, if this is the instrument or if this is the procedure, you have to start from the basic, the plan of agenda. Okay, so Sarah, we are going to start our meeting with an indications of the PESI, the contraindications, the alternate options, the procedure, the preparations, the procedure of insertions, any complications, and the post-procedure care and the follow. So this is a whole agenda we will discuss within a minutes and how it sounds to you. Then ask how it sounds to you. So start teaching, then start teaching, talk, repeat, ask for feedback, give another appointment to meet you for further practice and give the reference sources. Tell him where he or she can go for further information. You will give her the guidelines, websites, or links of the videos from where she or he can see how to insert the pessaries. So this is all about the template, how you go through a teaching station. Follow this template in all teaching stations. So interact with your junior colleagues. Put in mind the patient safety. Communication with the patient is very important. And if she does it correct, then say excellent, perfect, good job, praise her. If she does it wrong, says it, don't say you are doing wrong. So this, say like this is a good start, but if you would do in this way, that would be more better. So encourage her to do the practice. So this is all about the teaching templates. Now the domains which are assessed in the teaching, that are the communication with the colleagues. How will you communicate? These are the points which are coming in the communication with the colleague. How you introduce yourself to your junior trainee. Explain the purpose and agenda of the session. Checking background knowledge. Setting friendly environment. यहाँ पे आप उसको रूडली या ऐसे नहीं बोलोगे कि मैं आपकी सीनियर हूँ और चुप करके बैठो और मुझे मैडम बोलो. No, you have to setting friendly environment. Using appropriate language. Invite questions. Appraise. Check understanding at regular intervals. Like, am I clear till now? Am I clear? I am making any sense? तो वो आपको रिप्लाई कर देगी yes ma'am, it's clear to me. So check their understanding at regular intervals. Encourage hands-on. Once you are doing your practice on the dummies or on the mannequins, you have to give her hands-on. She will do after you will perform it. So use of the drawings, non-blaming, humiliating atmosphere in the feedback sessions. Asking for the colleague feedback. Also, eye contact and body language is very important. ऐसे नहीं कि आप अपने colleague को देखें ही नहीं और आप book में देखें या dummies को देखें नहीं. You have to interact with your colleague and eye contact. Body language and your eye contact is very important. That indicate you have a good communication skills with your colleague. Coming to the information gathering, what information gathering you need in the teaching station, that is checking his background knowledge. That is information gathering, whether she knows it before that or insert it before that. This is usually marked as a part of the communication with the colleague. The communication with the patient in the teaching station, कैंडिडेट यही बोलते हैं ये तो टीचिंग स्टेशन है, मेरे साथ तो जूनियर कॉलीग है, मैं इसको तो पढ़ा रहा हूँ, तो यहाँ पे मैं पेशेंट से कैसे कम्युनिकेट करूंगी. You have to communicate with the patient just if you are doing the procedures in the dummy. So dummy is just like your patient. You have to introduce in front of the dummy that this is your patient. So introduce self by name and role to the patient and obtaining consent to carry out the procedure. अब consent नहीं लोगे, it means you are not communicating with your patient. Keeping mom informed throughout. If you are taking the consent, उसको बोलेंगी कि पैसरी में इंसर्ट कर रही हूँ, अभी मैं पैसरी इंसर्ट कर रही हूँ, ठीक है. So keeping mom informed. If you are doing the episiotomy, you inform the mother, I am doing the small operation on your perineal area, that is a small cut, we call it the episiotomy. Throughout the procedure, what you are doing with her. So these are the communication with the patient, and also mark as the patient safety. If you are not informing her, mean you are not patient safe doctor. If you are not taking the consent, mean you are not patient safe doctor. These are also coming in the patient safety. What other points which are coming in the patient safety, जो आपको ख्याल रखना है कि ये आपने चीजें जरूर पूछनी है. So obtaining the consent, when to intervene during the session. आपने कब intervene करना है. The actor will deliberately commit mistakes. वो mistakes करेंगे तो आपको वहाँ पे intervene करना है, right? So relevant safety points like WHO checklist, swab counts in the surgeries, analgesia, estimate episiotomy in the instrumental deliveries, involving seniors. When you involve the seniors, so most importantly, not lying about things you don't know. कभी कभी ऐसा होता है कि मुझे चीज का पता नहीं होता और फिर मैं उल्टा सीधा उनको बता दूं. No, this is a lie. So don't lie. If you don't know, you say that okay, I don't have any further information about it, or I don't know furthermore. I will go and search the literature and then inform you. So उसके साथ सच बोलें अगर आपको पता नहीं है, right? So don't lie. Applied clinical knowledge. Discussion should be evidence-based according to the relevant GTD and applied to the situation. Like if you are there is the station of the varus needle and you are discussing the second report, this is irrelevant. Just go to the varus needle and how to introduce and insufflate the abdomen. So discussion should be evidence-based and apply to the situation thought. So here we are discussing the pessary insertion. So there is no discussion of the PubQ classification that are not really related to the pessary insertion. So we are focused on the pessary insertion to save our time, because we have 10 minutes to discuss all these in the 10 minutes. So focus the points what the examiner is asking, what your task is asking. So let's see the practice. You are about to see Saira, who is taking her IMM exam. She wants you to teach her about the ring pessary insertion. You have 10 minutes, during which are you expected to conduct a teaching session on the pessary insertion and answers the doctor concerns. So how I start? I will read this in the 2 minutes and make my bullet notes. Hello, I'm the registrar and you are? Nice to meet you. Saira, I came to know that you have your exam around the corner. How's your practice so far? Preparation so far? I wish you the best of luck. I understand you want to know more about the pessary. Is that right? Can you tell me why you are interested in the pessary insertions? Saira, have you ever seen or inserted the pessary before? So what are you expecting to get out of this session? I'll just give you a quick overview regarding what we will be covering today. I'll show you the different types of the pessaries, the indications, contraindications, which are important safety points that need to be fulfilled before inserting the pessary. I'll show you step by step how to insert the pessary, and after each step, I'll let you to repeat it after me. Then we will discuss the follow-up. At the end, I'll provide you with some useful website links and the videos. How it sounds to you, Saira? Saira, pessary is the device that is made out of the latex, silicone or vinyl. It is autoclavable and comes in different sizes and shapes. It's used in the pelvic organ prolapse. It stretches the vagina to treat the pelvic organ prolapse. If you see here in this picture, this is the, there are two types of the pessaries, support pessaries and the space occupying pessaries. These are the support pessaries, ring pessary, shelf pessary and the cube pessary. These pessaries are used in the mild type of the uterovaginal prolapse and sexually acting women. The second type of the pessaries are the space filling pessary. This is the cube pessary. This is the gel horn, and these are the donuts. These are the space occupying pessaries, and they are used in a woman who are not sexually active and who have a third degree uterovaginal prolapse. So can you quickly tell me different types? Good, Saira. So coming to the indications, do you know why we insert the pessary? What are its indications? So women who are not fit for the surgery, who refuses the surgery, who have pelvic organ prolapse with a pregnancy, or want to have any children. So can you repeat some indication for me? Coming to the contraindication, which are important safety points you need to keep in mind before inserting the pessary. They are active genital tract infection, vaginal mesh erosion or mesh inserted, medical or social reason which cause the woman not to be compliant with the follow-up is very important. If it is not compliant, that is the contraindications. The last one is the latex allergy. If so, then you can offer a silicone or vinyl pessary. So, Sarah, can you repeat some contraindication for me? Good, Sarah, you are a good learner. Let's go on to our patient. The first thing you will do is take the history to ensure she does not have contraindications. Take an informed consent from her. Ask her to write. Then come make her endorse the lithotomy. Put her in the lithotomy position. Then examine her. You want to determine which size is suitable for her, that is comfortable, and stay inside. I'll show you here in the dummy. In this mannequins, you do a vaginal examination. Insert your 2 fingers of the dominant hand like this and measure the distance from the posterior vaginal fornix to the symphysis pubis. To also confirm the pelvic organ prolapse degrees, the PubQ classifications, and the ulceration or atrophy while doing the pelvic vaginal examinations. So, Sarah, would you do it, please? How you assess the size of the pessary? Good, excellent. So this is the ring pastry. I'll wear how I insert this. This is the ring pastry. I will wear first my glass, apply lubricant to the leading edge like this. With my non-dominant hand, I separate the labia. With my dominant hand, I'll insert the pastry at right angle because it can be uncomfortable for the patient. I'll slip it like this, upper edge of it pressing against the anterior vaginal wall and lower end pressing against the posterior vaginal wall. Am I clear, Saira? Okay, so here is the pastry. Now you can show me how to insert it. Good, excellent, Saira. You are a good learner. You did well. After that, we ask the patient to walk around, go to the bathroom twice. When she come back, ask if she has any discomfort and was able to urinate. Examine her to see the pastry is in place, meaning the size is appropriate. Am I clear till now, Saira? If the size is appropriate or she could not wipe, we will change it to a different size. So, Sarah, coming to the follow-up, her first follow-up will after 2 weeks. You ask her if she has any bleeding, pain, or discharge. Examine her to remove it, clean with soap and water. Examine vagina to see if any pressure point or ulcer. If all is good, reinsert it and teach her to remove, clean, and reset it. Tell her to do it weekly. Our next visit will be 2 months, then 6 to 12 months, where she would go the pastry clinic specialist nurse to change it for her. If she is unable to change the pastry alone weekly, she will have frequent visits every 2 to 3 months for cleaning and reinsertion of the pastry. Am I clear, Saira? Good. So, Saira, what do you think? How was the session? Do you have any questions so far? Thank you, Saira, for your time. These are some links, videos on the pastry. If you want to know more about pastry, I would be delighted to teach you again.